Good afternoon and morning to you, those of you west of the Rockies. Welcome to the webinar, The Changing Role of States in Long-Term Services and Supports. Thank you for joining us. My name is Joshua Ewing, and I'm a policy specialist here with the NCSL Health Program, covering long-term care issues for the conference. I'll be your moderator for the webinar today. We have what I think will be a very informative and interesting webinar. But before we begin, I'd like to take a moment to thank the SCAN Foundation, whose generous support is helping us bring the opportunity to you today. Okay, now let's get down to business. We're glad to have you here to learn about the changing role of states in long-term services and supports. Today, we are fortunate to have two individuals with us who have been leaders in this field for many years, Paul Saucier and Patty Killingsworth. A quick reminder before we get started, you may ask questions at any point during the webinar. Simply type your questions into the box on the right-hand side of the screen. All questions will remain anonymous, and we will get to as many as we can during our Q&A session at the end. Our first presenter today is Paul Saucier. Paul is Director of Integrated Care Systems at Truven Health Analytics. He has over 20 years' experience conducting qualitative research, policy analysis, and program design in the areas of aging and disability. He is the author of numerous best practice briefs, option papers, technical assistance documents, and journal articles. Prior to joining Truven Health in 2010, Paul was director of the Cutler Institute for Health and Social Policy at the Muskie School of Public Service, University of Southern Maine. He has also held positions with the National Academy for State Health Policy and the Maine Legislature's Nonpartisan Office of Policy and Legal Analysis. Welcome, Paul. The floor is now yours.
Thank you, Josh. I'm happy to be with you today, and I think Patty and I provide a good team for you. I'll talk about what's happening nationally with managed long-term services and supports, and Patty will be able to tell you much more specifically what's happening in her world in Tennessee. So I'm going to talk about first, just to make sure we're all thinking about the same thing, define managed long-term services and supports. And then I'm going to talk about why states are rapidly moving in this direction and give you a status update about that. Talk a little bit about the populations that are being included in managed LTSS. And then I'd like to finish with a description of some of the major stakeholder groups and what they are concerned about with these programs. They are not without controversy, and they have been, I would say, safe to say, difficult to implement everywhere they have been implemented, though that's gotten better as more and more states have figured out how to do this well and engage stakeholders. So first of all, why would states be looking at new ways to do long-term services and supports? Well, it's obviously a big part of the Medicaid budget in every state. These are national figures for fiscal year 2011, $136 billion spent on long-term services and supports, about a third, almost exactly a third of the overall Medicaid expenditures in the country. So it's a big chunk of change. And if you're looking to provide Medicaid more efficiently, it's pretty hard to do that if you don't address long-term services and supports. What's the purple 136 billion there, things that are included in that, and I'll talk more about this in a minute, but we're talking about institutional services, which includes nursing homes and intermediate care facilities for people with intellectual disabilities. And we're also talking about a whole range of community-based services and supports, those that are provided through home and community-based service waivers under Section 1915C, but also an increasing number of state plan options that states are using, have been using personal care and home health for a long time, and now states are looking at 1915I options and J options. So pretty much anything you could think of that would be long-term services and supports is in that number. So long-term services and supports, first of all, for people who aren't familiar with the term, it is being increasingly used and essentially is replacing the term long-term care. So if some of you are confused by that terminology, we're talking about what we used to call long-term care, the whole range of community and institutional services. And when we add the managed part to it, managed long-term services and supports, we're talking about a service delivery and payment approach in which the state Medicaid agency contracts with managed care organizations rather than interacting directly with the providers. And it expects those managed care organizations to be accountable for the quality of long-term services and supports that are delivered and also the costs for whatever populations are included in the contract. Managed care organizations here includes the whole range. Several states are using HMOs as their contractors. There are also provider-based organizations that are accepting contracts for managed LTSS. And in some states, there are county-based organizations that are serving as the contractors. We use this definition broadly to include Medicaid-only programs, but also the increasing number of Medicaid programs for dually eligible beneficiaries that have been stimulated and prompted by the Affordable Care Act. So whether it has only Medicaid in it or Medicaid and Medicare, if it has long-term services and supports, we're including it in the definition. The target groups include older persons who are 65 and older and adults with physical disabilities. Those two first groups are often included together in these programs, but not always. People with intellectual and developmental disabilities, not as many states, but a growing number, and more likely to be in a program, a specialized program only for the population, though that too is not always the case. And then children with disabilities are sometimes included. Why are states adopting managed long-term services and supports? Well, states in the long-term service and support arena have been working on system balancing for a long time. That has been the major policy thrust in most states for certainly more than a decade. And managed long-term services and supports essentially constitutes another tool to achieve that objective. So by aligning the financial incentives, states are hoping that MLTSS will help them increase access to community services and decrease inappropriate use of institutional services such as nursing homes. And the programs are generally set up in such a way that both the institutional and the community costs are included in the capitated payment to the managed care organizations, and so the incentive is right for that to happen. And in fact, we're seeing increasing evidence that these programs do advance that objective. Better experience. LTSS, more so in some states than others, but in many states has been very much a separate standalone program that operates outside of the healthcare system, or parallel to it, I should say. And so part of the hope is better coordination of the LTSS services with other things that people use, integration with primary and acute services, and therefore a better experience for the user who has more things coordinated for them. The hope is that that leads to better outcomes when the person is treated as a whole person with all aspects of their life considered, and as a result can have better health outcomes, better functional outcomes, and really important for these populations, better quality of life. There's a hope of lower costs in these programs, and I have to say that this is the area where the evidence is most mixed, but definitely many states are looking to save money. There's pretty good evidence that these programs result in lower per person expenditures because of the substitution of more community services and fewer institutional services. But the programs don't always overall save money, and sometimes that's by design. States have used these programs to reinvest the savings in eliminating waiting lists, for example. So depending on where the savings go, there may or may not be an actual budget savings at the end of the year, but more people may be served, et cetera. And finally, purchasing strategy. Many states have included other population groups in managed care for many years, and LTSS is the last frontier that will allow them to unify their purchasing approach within state government so that everything comes under the managed care rubric. MLTSS is growing rapidly. I should have included an earlier year number here for you to give you a sense of what's happened over the decade. We did a baseline study in 2004, and at that time there were 8 states that had programs and about 100,000 people who were receiving LTSS through managed care. In 2012, when we took another look, the number of states had doubled to 16, and the number of people had almost quadrupled to 389,000. So significant growth, but over several years. The pace of growth has definitely accelerated, and as I said before, that's been stimulated to some extent by the Affordable Care Act, though the recent growth is coming not necessarily from the dual eligible initiatives, but from states that are either expanding their Medicaid-only programs or creating Medicaid-only programs. This year, 2013, there are 18 states with programs and about 550,000. Next year, we're projected to go to 24 states and over 1 million, and I'll talk a little bit more about that projection in just a second. So these are the 18 states that are enrolling people into MLTSS now. If you're from a state that is enrolling and not pictured on this chart, please let me know. But as far as I know, the most recent additions, Kansas and Illinois, came on in 2013, and the other states were providing managed long-term services and supports before that date. Expansions are also underway, so states that have had programs for a long time continue to grow them. The biggest examples of that on this map are Texas, Florida, and New York, all of which are engaged currently in expansions of their programs. In terms of the population groups, I talked a little bit earlier about which population groups are included, and you can see here that the older people, 65 plus, are the most often to be included in these programs, with 15 of the states enroll them. And then people with physical disabilities, as I said, often included in the same program as people, as older people, 11 states there. But you can see that the other population groups are not far behind in terms of the number of states that have enrolled them. 9 each are people with intellectual developmental disabilities and or children. And looking ahead to next year, it will be a significant year. Not only are there 6 more states that seem pretty certain to come on, but a number of states are going to expand and or continue expanding. The best example of the a big expansion that's scheduled is in California, which has had a small program for many years dating back to social HMO. But in 2014, it is scheduled to implement what will be the largest dual eligible initiative in the country, which, if it goes as planned, will overnight, well, not quite overnight, but will become the largest program in the country. So there'll be additional enrollment in a number of states, and then you can see the lighter colored states are ones that I felt pretty confident putting on this map as projected. I say pretty confident because, as I said at the introduction, these programs are challenging to implement, and just about every state on this map took longer to implement their programs than they had originally thought they would or had originally projected. But the ones that are projected to come on in 2014 have already had postponements and delays, and so they seem pretty reasonably poised to implement next year. Finally, I do want to leave you with some of the concerns that stakeholders raise with these programs. These are substantial programs. They really change things. They're not cosmetic. The service delivery changes, how people access their services change, and then on top of that, there's all the usual concerns that people have about managed care. And so all of the questions here on if you're a state official that's considering going down this road, these are all questions that can be answered, or if you're a legislator, you can expect to get these questions from your constituents. But the good news is they're all questions that can be addressed either through policy or procedure or through contract language. But the state does have to make a conscious decision about them and needs to really proactively work with stakeholders, or they're going to, or the state will be on the defensive as stakeholders grow more and more concerned that their questions are not being answered. So what are some of the major ones? For beneficiaries themselves, will my benefits be reduced? So part of that is a question about, is the benefit package changing? But part of that is a question about, will my hours, the hours of personal care that I get, be reduced? Will I lose my existing providers? So if I have a personal care worker that I have trained and that I am really happy with, that's been with me for 8 or 9 months, am I now suddenly going to lose that worker? Will I move out of my, well, I have to move out of my home, wherever that home is, my nursing home, my assisted living facility. Will I lose control of how my services are provided? So one question that has come up a lot is in states that have a self-directed option, an option where the beneficiary can hire and direct their worker, will they still have that option? And most states are incorporating that into the program, but again, you have to be explicit about it. Who will help me if I have problems with the managed care organization? So is there going to be a trusted community organization of some kind that I can go to, or am I going to have to rely on an 800 number at the managed care organization? LTSS providers also have a set of practical questions. Will I lose my existing customers? Will I be allowed into the network? So assuming that I want to do business with a managed care organization, are they going to let me do business with them? Will my rates be cut? Is this just really about a rate cut and nothing else is going to change? I'm just going to be paid less money. Will my payments be delayed or denied? So will the billing be such that I'm going to have a lot of problems, and this is an area where providers have had issues in other places, so again, something that requires some attention. Case managers probably have the most to lose in all of this because it is the area that tends to change most consistently. In most cases, the managed care organization will bring case management in-house, so they will do the case management at the managed care organization. Now, often they will hire the case managers who've been previously working for other organizations, but nonetheless it represents a change. And so case managers are going to be worried about that. Am I going to lose my job? And depending on the state that you're in, your case managers in LTSS might be state employees, they might be county employees, they might work for area agencies on aging or centers for independent living, or they might work for third-party private contractors. But that will be a concern, what's going to happen to those positions. And even though it's a hard question, being explicit about it up front is probably a good idea. The advocates, finally, also have a set of very practical questions that, again, can all be answered. Will beneficiaries get conflict-free advice and assistance? So where's that going to come from? Will due process rights be diminished? So will there be, streamlining that results in the various steps that people have somehow being reduced to fewer steps? Will the contract be tough enough? The advocates have been monitoring contracts around the country, and they know what a good contract is, and they'll definitely be looking and wanting to know that it's a good contract. And then finally, and this is a great segue to Patty, will the state have enough staff to enforce the contract? So these programs don't mean that the state is able to then lay off all of their staff because now a private organization is doing the program. It is really important to have adequate enforcement and monitoring so that you get the program you want. And so with that, I will pass it on.
Thank you, Paul. As always, great job. Remember, everyone, you may ask a question at any point during the webinar. Simply type your questions into the box on the right-hand side of the screen, and remember that all questions will remain anonymous. Our next presenter is Patty Killingsworth. Patty is Deputy Commissioner and Chief of the Long-Term Care Division of TennCare, the Medicaid program in the state of Tennessee. Patty has served in this capacity since 2007. She came to Tennessee in 2001 as a Special Assistant to the Deputy to the Governor for Health Policy. She was appointed Assistant Commissioner and Chief Administrative Officer for the TennCare Bureau in December 2004, with responsibilities for the Division of Member Eligibility and Medical Appeals Services. Prior to coming to Tennessee, Patty worked in my home state of Missouri as a Deputy Director with the Department of Mental Health. Patty, the floor is now yours.
Thank you so much, Josh. It's a pleasure to be with everyone today and to talk a little bit about Tennessee's experience in implementing managed long-term services and supports. I'd like to start with just a brief overview of our Medicaid program and how it works to set the stage for the discussion. We have done managed care now for nearly 2 decades in Tennessee. We haven't always done managed care well. And so what I'd like to do or hope to do throughout today's discussion is to try to infuse some of the lessons that we've learned, primarily in implementing managed care broadly in the early years of the program, but also more recently as a part of integrating long-term services and supports into that program. We do operate under the authority of an 1115 demonstration waiver with the federal government, and we use managed care to cover our entire Medicaid population, including some people who otherwise would not qualify for Medicaid. So everything that we have in our Medicaid program is in managed care, and all of the people that we serve are in managed care, about 1.2 million people, or roughly 1 in every 5 citizens in the state. In that program, all of our physical health, all of our behavioral health, and since 2010, our long-term services and supports for seniors and for adults with physical disabilities are a part of that program and are administered by 2 managed care organizations located in each of the 3 regions of our state, and all of those programs operate at full risk for those services. The only services that are not a part of managed care in Tennessee at this point are long-term services and supports for people with intellectual disabilities. That includes both the institutional benefit and our HCBS waiver benefits for that population, but the population is in managed care for their physical and behavioral health services. I'll skip by some of the other sort of structure of our managed care contractors, which I've included for your information only, and move on to talking about our MLTSS program, which we call Choices. And I'd like to start that discussion with a little bit of the history about why we did managed care. Basically, all of the things that Paul talked about, all of the state objectives and reasons that states look at implementing managed long-term services and supports are things that we took into consideration. I would like to point out that we didn't set out primarily to do this as a savings initiative, and in fact, we did not contemplate savings per se. What we contemplated was more cost-effective service delivery and the ability to reinvest those dollars in serving more people in our home and community-based services waiver. But we set out to really integrate and coordinate care in a better way, to eliminate some of the fragmentation that existed in the system previously, to really refocus our system on creating more home and community-based options for people and expanding that as the benefit of choice for people who need long-term services and supports. And then finally moving away from what had been a historically very heavily institutional program that was always dependent on new dollars to be able to make home and community-based services available to more people, and really being able to use our dollars more cost effectively to serve more citizens who need care. We began with a legislative initiative not because we had to, but because we really felt that it was important to build support for such a fundamental and transformational change in the state. And it really started at the very top of our leadership with then Governor Bredesen in his State of the State address in 2008. That launched a very comprehensive legislative initiative, and I've included a link to that piece of legislation as it was passed in 2008. It was sponsored by members of both parties and both houses, and was passed unanimously by the General Assembly without a single no vote ever in any committee, subcommittee, or on the floor during an election year, which is not an easy thing to accomplish. And we think that part of the reason is that we had very, very broad stakeholder engagement in that entire process. Literally from the morning after the Governor's State of the State address, we had meetings arranged with all of the different stakeholder groups, including providers and advocates, and we began to work with them on understanding what their key concerns were and how we could address those concerns as part of the design of the program, and also on really helping to educate people about the very important objectives that we wanted to accomplish. Again, focused around better coordination, better quality of care, focusing on improved access to more cost-effective home and community-based care, and being able to serve more dollars and really positioning the state well for the aging population that is to come in the future. The design of our program then really tried to take into account all of the input and feedback that we had received, as well as making sure that it was set up to achieve our intended objectives, and quite frankly, to create a program that was financially sustainable for the state over the long haul, given some of our very difficult history in the TennCare program. So essentially what we did was to bring nursing facility services and our home and community-based services waiver into an existing managed care program. We did not do a new procurement. We had gone through a competitive procurement recently and elected to simply amend the contracts with our existing MCOs in order to add those benefits into the program. The way that it is structured, as Paul mentioned, is frequently the case, and quite frankly we think is the best way to structure the payments is a blended capitation payments for physical, behavioral health, and long-term services and supports, with managed care organizations at full risk for all of those services, including nursing facility services, and to make that not a time-limited option. It's very important that that a nursing facility that a managed care organization is incentivized to want to provide cost-effective care in the community whenever possible. It's also very important that to the extent that they don't provide a sufficient or appropriate level of services, that they would be financially responsible for the more expensive institutional benefit. So it's really all about appropriately aligning the incentives to drive the kind of behavior that you're looking for. In order to ensure that we created a sustainable program, we do have an enrollment target, which functions as sort of like a cap on the total number of people that can receive home and community-based care. But we've been able to keep pace with that particular cap and with demand, and to eliminate all waiting lists for the program under this new program design. We have individual benefit limits, and we also have what's called an individual cost neutrality cap, which simply means that the cost of anyone's care in the community can't exceed what it would cost to provide their care in a nursing home. Again, part of making sure that the program is financially sustainable over time. From a member perspective, it's important that they continue to have freedom of choice. It's also important to them that the care coordination that is provided by managed care organizations is both comprehensive in nature and very member-centered in terms of its approach, really focusing on what's important to the member. We actually added consumer-directed options for home and community-based services for these populations as a part of moving to managed care. They had not existed previously. And we also added, as a very important quality component of our program, a requirement to have an electronic visit verification system, which basically requires providers who come into a member's home to log in and log out at the beginning of each visit. It's important from a program integrity perspective, but it's more important because it allows us to know immediately if a scheduled worker doesn't show up on time, and holds the managed care organization as well as the provider responsible for immediately responding to address and avoid that potential gap in care. So we have a program design, and the next thing is making sure that we're ready to actually administer that program well. And Paul talked a little bit about this. These are some of our lessons learned really from the very early years of the TennCare program, when many of these things were not in place back in 1994 for the program to be successful. Making sure that the state Medicaid agency has not just the number of staff, but the degree of expertise they need to appropriately manage care. Making sure that the contract is extremely well defined, a very comprehensive readiness review strategy, and then process and mechanisms and staff to provide ongoing monitoring and quality oversight of the program. And I'll talk just a little bit more about each of those. Our state Medicaid agency is really organized around the delivery of managed care. Not only are we stronger in terms of numbers of staff, but we're stronger in terms of the level of expertise that we have within the organization to oversee multi-billion-dollar health plans, and that's really what it takes in order to manage managed care well. If you look at how we're structured, you would see that we're structured very much like a managed care organization in terms of our network, in terms of our individual divisions, and that all of those divisions really work together in a comprehensive way to manage the health plans and to manage the programs. The Medicaid agency is then supported by a number of very important contractors who assist us in our work, including an actuary, an external quality review organization, and a number of other entities that we've listed here. While every state might have a slightly different list of contractors, you can almost assure that every state will need some contracted support in terms of implementing managed long-term services and supports well. Finally, we work very closely with our partners and other stakeholders, which we define very broadly because there are many people all the way down to the individual taxpayer who have a vested interest in how well we manage the program. And we want to assure all of them that we are integrally involved in the day-to-day program management of not just our MLTSS program, but our managed care program broadly. It is not a situation where you can contract the program out and expect that it's okay. We talk with our health plans on almost a daily basis. We receive voluminous data from them and monitor the work that they do for us on an ongoing basis. It all begins with a well-defined contract. Our contract is in excess of 600 pages. I've included a link if you're interested in reviewing any of it. We did develop many sections of that of that contract in consultation with our managed care partners and with stakeholders. We have a 6-month review cycle where every 6 months we make amendments to the contract. And you will note in particular that there are all sorts of enforcement mechanisms in the contract to ensure that the requirements are actually met. I won't spend a lot of time talking about the contracting considerations. There are a number of them, both for members and providers. I think Paul hit many of these earlier when he talked about the various concerns that stakeholder groups have. It's important that the contract define how the program will be structured to help address those concerns and to mitigate any risk that could result from a transition to managed care, particularly around care for members and ensuring continuity of care for members, and around payment and assuring continuity of payment for providers as you transition to a managed care delivery system. The next component of state capacity is really around having a comprehensive readiness review strategy. So if you have a program design and you have a contract that defines what your expectations are, how do you know if health plans are actually ready to fulfill that contract? And it really revolves around a very elaborate readiness review process, which takes a minimum of several months. We began by looking at paper documents, essentially, understanding how processes have been described and set up, and then we moved to actually reviewing those processes on site. So you've told me how it's going to work, now show me how it's going to work. Let me see your systems, let me see them talk to each other, let me actually observe how those things happen. Particularly for MLTSS, it's important that readiness review focuses extensively on care coordination, which really is the cornerstone of the program, and understanding exactly how care will be coordinated for members, how members will be tracked through the system. We spend a lot of time testing connectivity between systems and making sure that data can be exchanged in a seamless way, with testing from the beginning of sending an eligibility file to a managed care organization all the way through the payment of a claim and getting an encounter back which shows that a claim can be paid for those services that have been rendered. And then finally, we have a number of other activities that we do as managed care organizations develop their networks and as they prepare to transition members into managed care, which looks at making sure that the networks are sufficient and that services are authorized to ensure continuity of care for members. All of that takes a great deal of time and it takes a great deal of resources and can't be shortchanged if you want to have a good program implementation. Finally, that's really just the first step, because once the program goes live, it's important that there are ongoing processes in place to monitor and oversee the program. That includes ways of looking holistically at the system and also ways looking at individually at what members are experiencing. There need to be ways for you to know and identify gaps in care and address those quickly. There need to be ways to understand how the program is working from the member's perspective. And all of that needs to be a part of the program design, including, as Paul pointed out, some independent opportunity for members to go to if they're experiencing difficulties with the system. I want to talk a little bit about the time that it takes, because all of these things are a part of an overall process that for us began in early 2008 and did not move toward implementation until 2010. So we started with a comprehensive piece of legislation that was passed in May of 2008. We began a year-long negotiation with our federal partners to actually get approval for our program. And that program was finally approved in July 22nd of 2009. We had been working all of that time on really developing the MCO contract requirements, but had to then move through the final contracting process with our managed care organizations. And then all of that set into motion a number of other things that could not occur until those contracts were in place. So things like managed care organizations subcontracting with entities that they needed to subcontract with, developing and contracting with their network, making sure that providers receive lots of training and information and were prepared for the transition, making sure that we developed clear program rules and policies and conducted the training that we needed to conduct for our own staff doing all of the IT system design, and then finally the readiness review components that we previously talked about. And all of that had to happen before the program could go live, keeping in mind that we did not do a new competitive procurement, which at a minimum would have added another 6 months to this entire process. So a lot of times when you hear states talk about moving quickly to managed care, one of the things we want states to understand is the amount of time that it really takes to make a transition like this well, with our implementation actually then commencing in 2010. We are now almost 3 years old. Well, I guess we are 3 years old in the program statewide. We don't have 3 full years of data complete in terms of some of the data that we measure for a look at in terms of the success of the program, but I want to highlight a few things that we've seen. We've seen the number of people receiving home and community-based services grow significantly, more than doubling just during the first 2 years of the program. We've seen the number of people receiving care in a nursing facility decline fairly significantly also during those first 2 years. We have seen, as people come into the program, the way that they're choosing to access services change significantly, with more people choosing home and community-based services on the front end. We've seen the average length of stay in a nursing facility decline, and we've seen a number of transitions of people moving from nursing homes to home and community-based care during the first 2 years of the program, and also during the 3rd year of the program, where the data is yet incomplete. This next slide just shows you a quick picture of where we came from before we integrated long-term services and supports into managed care, and where we are today, with really the 12,960, which is our membership today, compared to the 6,000, which is what we were funded to provide services to in the program before MLTSS, and we've been able to accomplish that without going back to the General Assembly for any sort of an expansion request to eliminate the waiting list and fund those additional people in the home and community-based services portion of the program. The next slide is just, again, a quick look at where our percentages of enrollment were before we began the program, with 17% of our population receiving care in home and community-based settings, and now over 40% of our population receiving care in home and community-based settings just 3 years later. And then in terms of other successes, focusing on the fact that people are actually getting the services that they're supposed to get, and we measure that on an ongoing basis. Not only are they getting them, that they're getting them on time, and some of this is the data that we're able to track because of our electronic visit verification system. We have continued challenges, as we always do, in any type of LTSS program, particularly with respect to continuing to shift the balance of our expenditures away from institutional care and into home and community-based care as we move forward. And we continue to experience challenges with the fact that most of our population in long-term services and supports are also Medicare eligible, and the way that Medicare benefits are utilized oftentimes tends to drive the use of institutional care in the Medicaid program, something that we're hoping an opportunity to impact in the future through greater efforts to integrate Medicare services with Medicaid. I'll close with just a few of our key lessons learned, and then we can try to answer some questions that you may have. I always want to emphasize that managed care is simply a way of paying for services and contracting for services. It's tools and principles that can do really, really good things for the most complex populations, but only if we implement those tools in the right way. I also want to reemphasize again that in order to manage care well, it requires a significant investment in the state's capacity, particularly within the Medicaid agency, but also with other kinds of partners to oversee health plans. It takes a sufficient amount of time to design and implement a managed long-term services and supports program. I also want to emphasize, as Paul noted, that while there is certainly the potential for cost containment and savings in these programs, and we've certainly seen that in our TennCare program broadly, if you assume too much too soon, it can really undermine what you're trying to accomplish. And then finally, I always say be careful not to confuse the success of the model with the success of the implementation. So it comes back to, it's up to us to really be able to ensure that we implement the program in the right way. And with that, I will turn it back to Josh for questions.
Thank you, Patty, for that wonderful presentation. In fact, thank you to both of our fantastic speakers, Paul Saucier and Patty Killingsworth. We're now going to open the floor to questions. Remember, to ask a question, simply type your questions into the box on the right-hand side of the screen. And remember that your questions will remain anonymous. Our first question today is, as a state legislator in a state who is considering Medicaid managed long-term services and supports, what are the top 1 or 2 things I should be concerned with when we are considering making this move? And I think that could go to either Paul or Patty who would like to take it.
I certainly don't mind to start, and then Paul can jump in. I think I would point back to a couple of the things that I highlighted in my presentation that I think Paul did as well. First, I would say stakeholder engagement, being sure that you work with stakeholders broadly throughout those discussions, and if you decide to move forward in both the design and implementation. And then I would point to being sure that you have adequate state capacity, adequate time allowed, and appropriate expectations around savings as you implement the new program.
I would add really clear goals for the program, which I suppose Patty said clear expectations. Being clear why it is that this is happening, so that everybody in a very public way can then over time monitor whether the program is successful or not.
Our next question is, how are states managing the intense need for information for beneficiaries and providers as they move towards a managed long-term services and support system?
Maybe I can talk about what I've seen across several states, and then I'm sure Patty could talk more specifically about what they've done. I think of this need as really being in 2 phases, the planning phase and then when the program's actually implemented. In the planning phase, states are now, are almost automatically having a website around the planning effort, and some of those websites are better than others, but having a place where you can go for updates, information, and so on, regardless of who you are. Having a communications plan, and that plan really should think about the different stakeholder groups and what kinds of communications that they need to receive, beneficiaries, providers, community-based organizations, and others. Having a broad-based advisory group, I think, is a good way, even in a big state, to get some representatives of the various communities able to communicate then back to their constituencies. So all of that in the planning. And then I think with the implementation, you move to direct communications. And, those are not easy because, as everybody knows, Medicaid addresses tend to be out of date, et cetera. But, typically the pattern is direct communication to beneficiaries about what's going to happen, and then about the fact that it is happening, and then finally, the fact that it has happened, so letters. And some states then, if the beneficiary hasn't taken the action that's been requested in the letter, will do a telephone follow-up to that beneficiary. Some states are offering in-home support for the beneficiary to make choices, but it again depends on the state. And also with providers, having direct communications with providers about what's about to occur, what's going to change, what they need to do. I could go on, but I think the lesson that I've seen in talking with states around the country is that no matter how much they've done, it has not been enough, and so you have to have a default mechanisms in place. Some people will not have heard about it, will not have taken actions, and so default mechanisms that essentially do not allow people to fall through the cracks if they simply haven't heard that they need to make a decision or do something.
And I think that's a great comprehensive response. I'll add only two specific examples that worked well for us. One is with respect to members really leveraging the stakeholder base, in particular the advocacy base, to also get information out to individual members in addition to all of the materials that we sent. And then with respect to providers, one of the things that worked well for us was a coordinated effort to train providers where the Medicaid agency partnered with all of the health plans to go into a region and to conduct joint trainings where all providers heard the same messages and then also had specific access to the health plans operating in that region for more detailed and specific questions.
Thanks, guys. The next question is, can you please explain what an employer authority model within consumer-directed options for core home and community-based services is?
Sure. So employer authority basically means that what people have the opportunity to do is to act as the employer of record, essentially to select and to train and to oversee and supervise the staff who will deliver certain kinds of their care. It's not all of their care. It's primarily the hands-on kinds of benefits that members receive in their home, like personal care or attendant care kinds of services, as well as in-home respite. We use a fiscal employer agent, an entity who actually manages all of the payroll and all of the tax reporting and all of those things that needs to occur from a payment management and tax management perspective. But we in the program currently do not give members a budget to manage. Their services are identified through a person-centered planning process, and then they have a choice of models, with one of those models being to elect to hire their own staff rather than using a traditional provider agency for those services.
Thanks. And Patty, a related question. How many people do you estimate began accessing a consumer-directed option for home and community-based services when that was added under your model?
We currently have just over 1,000 of our almost 13,000 members who are actively receiving services through consumer direction, and several hundred more who are in the implementation process of that.
Great. Paul, this question's for you. Given that you look at this issue nationally, can you talk about some of the outcomes you've seen in other states, and are they similar to Tennessee?
The one outcome that seems pretty clear wherever you look is the expansion of HCBS. You know, and some states have more documentation of that than others, but I'm thinking of Minnesota, Wisconsin, Texas have all produced good documentation that HCBS has expanded and that institutional services go down in one way or another, you know, number of people in or length of stay and so on. So that's pretty consistent with Tennessee. You know, the cost evidence, as I said early on, is mixed, and it's because, well, there are not many good cost studies, so there's not much evidence to begin with, and then the different cost studies have been designed in different ways that make them difficult to compare. But it does seem, from what you can see, that the cost per person does go down in these programs. Then it becomes a question of how those savings are directed. And some states seem to have done a better job than others at either capturing those savings for the state and or reinvesting them in an expansion of community services.
Great. Is the increase of home and community-based service participants by choice, or is it because of the new medical qualification requirements, and has this been measured?
So that has to be a question that's directed to me, because one of the things that we did in our program last year in 2012 was to change our nursing home level of care requirements to better target that benefit to a higher acuity population. just by way of context, our previous requirement had been that one significant ADL deficiency qualified a person for nursing home care. I dare say we probably had one of the most generous, if not the most generous, level of care standard in the country to get into a nursing home. We changed that and achieved about an 18% diversion rate of all new nursing home applicants to home and community-based services. But previous to that, we were still seeing significant redirection, if you will, in terms of how people were coming into the program and really choosing home and community-based services first rather than institutional care. Certainly this supports those continued efforts, but it's not solely responsible for the progress that we've seen.
Wonderful. One final question, because we're nearing the top of the hour. CMS released guidance yesterday about incorporating long-term services and supports into the EQR protocols. Have you guys had a chance to look at this guidance, and do you have any insight onto the impact this will have on managed long-term services and supports programs?
I saw that it came out, and you know, I haven't had a chance to really analyze it, so I can't say anything about the substance. My impression is that CMS simply wants to remind people that the EQR, the External Quality Review Organization, is a resource that states can use as part of their quality strategy as they move LTSS into managed care.
And I likewise have not had a chance to review the document thoroughly. I'll make a couple of comments. I do think that it's important that that we begin to think about, both in terms of external quality review, in terms of standardized quality measures, thinking about how they apply to managed long-term services and supports, having measures specific to managed long-term services and supports, similar to what we do for physical and behavioral health. And I think there's a lot of work going on in that area that's very, very positive. I will say that I think one of the recommendations specifically that gives me a little bit of pause is around holding MLTSS plans accountable for avoidable hospitalizations and ER diversion. And I think that's a very appropriate thing to do in an integrated plan where that MLTSS health plan has responsibility for the physical health benefit for that particular member. There are some MLTSS programs still where it's only managed long-term services and supports and not physical health. And beyond that, a significant number of these individuals are often dual eligible, which means their Medicare benefits, their acute care hospital benefits reside elsewhere, as do their primary care benefits. And part of the frustration that we're seeing is that it's very difficult to impact what's happening on that Medicare side of the house. We see that all too often driving poor utilization of managed long-term services and supports, which is why we're hopeful to see more opportunity and better opportunity for integration in the future. You can't hold health plans accountable for benefits they don't administer.
All right. Looking at the clock, I think that's going to bring a close to our question and answer period. Thank you again to our presenters and to all of you out there today for joining us. This webinar has been recorded and will be made available along with the slides on the NCSL website at this address next week. A quick note before we go, we will be hosting a full-day pre-conference at NCSL's Fall Forum in Washington, D.C. on Tuesday, December 3rd. The pre-conference will examine many of the topics you heard about today in greater detail. There will be presentations from national experts and opportunities for discussions with your fellow states who have made or are in the process of making the switch to Medicaid managed long-term services and supports. For those of you who will be attending our Fall Forum, I highly encourage you to join us on December 3rd. For information, you can visit ncsl.org/forum or email me at the address listed on your screen. If you have additional questions following the webinar, you may contact us here at NCSL in the following ways: by visiting our website at ncsl.org and searching long-term services and supports in the search bar, by emailing our health program staff at health-info@ncsl.org, or by calling our offices at 303-364-7700. Just ask the operator to speak with someone in the health program. This will conclude our webinar, The Changing Role of States in Long-Term Services services, and supports. Thank you again for attending, and have a great day.